All right, I'm going to introduce our second speaker of the day, Dr. Lucas, Sylvia Lucas, who trained here, right, at the University of Washington. And I thought you had a PhD. Oh, for 1 year. I'm sorry. Then you ran away. No, I'm sorry, but I mean your medical school.
Oh, of course.
I'm going way back. Okay. And I thought you had a PhD in pharmacology, but it was in neurophysiology. But you also studied pharmacology, so lots of. She gave a very good lecture last year on interesting drug interactions. And then came back to Seattle to practice, and has been with us since 2005, and is the director of the Headache Center, and also sees patients with MS, and also is a wonderful, wonderful resource and a very rapid-fire responder to questions on headaches, of which I have many. So,
but they're always so good, like exploding head syndrome. And she saw two. I haven't seen any. Anyway, thank you very much for the introduction. I'm very pleased to be able to talk about primary headache disorders. In the real world, headache, the real world has quotes around it. Headache is probably the second most common thing a neurologist will see right after back pain. But I know that in medical school I didn't have any lectures on headache, and in residency my mentor didn't believe in headache. It was a real weakness, and so we didn't learn anything about it. So was back pain. We didn't learn it, and peripheral neuropathy. There were a lot of things we didn't know about, but he loved the thalamus. At any rate, who am I talking about? Yes, Fred Tom. But other than that, I'd like to start with what at first glance will be a simple, straightforward headache, so to speak. But even the simple things teach us so much about physiology, and they're so very interesting. If this woman came to you, there are a few things I want to point out about the history. And one of my wonderful patients, Barbara, who graciously allowed me to use her many illustrations regarding her own headaches. You'll probably see some of her art throughout my slides. But so let's say you have a 22-year-old woman who comes in and tells you she has a history of headaches since childhood, and her father used to treat her by giving her a can of Coca-Cola, which would improve them. She only has, again, depending on how disabling headaches are, that only could be taken on mythical proportions, but she has 1 or 2 headaches a month. She divided her headaches up into regular headaches and migraines. And migraine tends to mean different things to different people. You always have to delineate a description of what people mean by migraine, kind of like dizziness as well. There's another word to try to tease out. Typically, her headaches would last a day, sometimes 2 days. They'd vary in location. They were predominantly unilateral. They'd start with throbbing, become vice-like, and she would have some accompanying features: nausea, rare vomiting, photophonophobia. In her case, the difference in headache type was basically, to her, meant for headaches that she didn't have to go to bed with. Those were regular headaches. The ones that were severely disabling were migraine. And she treated with ibuprofen, which was essentially ineffective. Sometimes it would decrease the headache somewhat. So the things that make you feel better about this as not being a serious, severe, potentially fatal process is the fact that they're episodic, and she's had them most of her life. And, of course, they come and go. What's interesting about the illustration is you can see there that it illustrates kind of a left unilateral type of pain. If you want to, if you think sticking pins in your left eye is painful, obviously she senses her headache mostly in the eye area. It was orbital, retroorbital type pain. She also illustrates something that I think Barbara didn't know when she drew this, but that we are finding out more and more when we talk to people who have migraine, is that people become allodinic. So, for example, they get tenderness. In her case, you can see not only over the scalp on that side, but also in the upper extremity and somewhat down the back. And we think this is a manifestation of something called peripheral sensitization, where it's almost as if the gain of the trigeminal ganglion increases. And I wish I had a little more time to talk about that, but basically if you look at animal models and you stuck in a recording electrode in the ganglion, you would find in a model, an animal model of headache pain, increase recording of electrical activity, spikes per second. So one of the reasons we classify headaches is to determine whether someone has a secondary or a primary headache. Do they really fit the bill for primary headache? Is it a secondary headache, something you have to basically has a structural underlying component, is hopefully treatable, and if you miss it, could have severe consequences. Primary headache disorders have also been very helpful in that over the last few years they've allowed a classification system that has really allowed us to study people with the same kinds of headache clinically and radiologically. Certainly secondary headaches may have warning signs. You could use the SNOOP category, but typically if it's somebody with initial headache, could be the worst headache of your life. Of course, you'd want to get imaging to rule out subarachnoid hemorrhage. A difference in headache pattern can also be important. So if you can have someone who looks like migraine, and for example, I had someone who did have migraine, and then you'll hear something like, oh, by the way, I have a short headache that I wake up with every morning, but it goes away in 2 hours, and then it goes away in 4 hours, and then you do the imaging and you find a dermoid tumor or something like that. So you can have apples and oranges. I usually image people who have progressive headache syndromes, a difference in pattern. If there's an onset with Valsalva or intercourse, and I'll talk a little bit more about that, then that is worth looking at as well. Obviously, anything in terms of abnormal neurologic exam, or if there are risk factors for secondary headaches, you'd want to image these folks. Without really delving into leading questions, because you can have people have as many headache types as the location, it is a good idea to ask people questions about how many different types of headaches, because of that very belief that location determines the kind of headache people have. If the receptive field of the headache is here or over the maxillaries, it's going to be a sinus headache. If it's in the neck, it's a tension or stress headache. And the receptive field is typically, again, in the trigeminal, either in the trigeminal area or in C2, C3, C4, and usually overrepresented in terms of V1. Could be bilateral, could be unilateral, but sometimes you will have people who have headache just in their teeth. Rare, but found. Age at onset, frequency, location, symptoms, duration, these are all things that allow you to diagnose migraine versus something else. And I'll show you the definition in a little bit. Time from onset to peak intensity may help you determine what dosage form you want to use for the medications that you'll use to treat your patients. Migraines are typically headaches that last 4 hours to 3 days. I mean, that's a bell-shaped curve. You'll get some people whose headache lasts a week. It's unusual, but not to get too nervous about it, like the patient is undoubtedly doing. The kicker between the two is how severe a headache is. Chances are you're not going to see people with tension-type headache because they won't come into your clinic, though they can mention that they have headaches, and these tend to be mild to moderate headaches. And sometimes people will treat them with over-the-counter products. But a migraine is moderate to severe, at least untreated. It's usually unilateral, but not always, and exacerbated by routine physical activity. Again, bending over to pick something up, turning your head fast. This is an indication of peripheral sensitization. People do feel the spinal fluid moving in the brain. So something to ask the patients about. Nausea, vomiting, photophobia, and phonophobia are very common. If you look at studies looking at the 1-year prevalence of headache disorders, almost half of the U.S. population is going to have a tension headache. 18% of women and 6% of men in the United States will have migraine, and this is having at least 2 a year in this study. The patients that we see in our clinic at the UWMC are typically patients who have chronic daily headaches, so greater than 15 days of headache a month, greater than 4 hours a day. The reason you'll see these people, I mean, it's an interesting process, because unlike other chronic diseases, migraine is going to be found in the younger population. You're going to have your highest prevalence between the mid-20s, and between about 45 and 55, it really tends to wear off, mostly in women because there's a hormonal component to that, but also in men. The highest incidence you're going to see is about 8 years old in boys and about 13 in girls. So the young boys tend to get it a little bit earlier than the young girls. Migraine with aura we talked about. If you want to follow IHC criteria, again, 2 of the following: one side or the other, pulsating, pounding, throbbing, moderate to severe, routine physical activity makes it worse, and nausea, vomiting, or light and sound sensitivity. The phases of a migraine headache, how fast do you go from 0 to 60, I think really is important, because most any headache medication that you use to treat patients is going to take 1 to 2 hours to reach peak plasma concentration. And so if someone takes 30 minutes to go from knowing they have a headache to their chief pain, that's certainly not enough time for the pill to work. The second issue is one of gastroparesis. We know that there's probably coactivity of the parasympathetic nuclei with the pain nuclei, or with the trigeminal nucleus caudalis, areas around the periaqueductal gray that are involved in modulating headache. However, there's also some evidence that the worse the headaches gets, the slower the gut moves. So if somebody has gastroparesis, you're not going to absorb a pill anyway. And so these are the people you might want to think would do better with an injectable, for example, or even a suppository. There's also a post-headache syndrome. Some people treat that, some people don't. It does respond to migraine-specific therapies that I'll talk about in a minute. It also responds very nicely to non-steroidal anti-inflammatory medications, which of course are much cheaper. About 18%, 20% of patients with migraine can have aura. Some people just have the aura without the pain. And I met yet another person today who gave me a perfect example of scintillating scotoma that I'll talk about later, but she didn't realize she had migraine because she never had pain. These attacks are fully reversible. They're usually visual about 80% of the time, but they can also be sensory. They can have speech or weakness along with them. And sometimes it's very hard to differentiate aura from an impending stroke, from TIA. Typically, and again, this isn't hard and fast, but for aura, these usually develop over several minutes, and I'm going to talk a little bit about that in another slide. But usually it'll take over 5 minutes. For example, if anybody's ever had an aura, and mine are usually visual, so you'll start seeing this little C, and then it'll grow and move out of the visual field, and it probably takes about 20 minutes. And they can change sides. Some people have them on both sides. They should not last longer than 60 minutes. Prolonged aura kind of makes you a little nervous for impending stroke, and though migrainous infarcts are very rare, they're not that rare. Lashley calculated the rate of expansion of his own visual. It's so nice when neurologists have neurologic symptoms because you get them a lot more detailed. But he really calculated the change of his scotoma to be about 3 millimeters per minute, and that really correlates very nicely with PET imaging of basically what you're looking at is a wave of depolarization. But why the visual cortex should be more susceptible to this spreading wave of what we think now is cortical spreading depression is really kind of unusual. And there's some and there's a lot more research that needs to be done there, but you can sort of measure it on PET scans, bold imaging, and it moves forward 3-4 millimeters a minute again.
And so why it spreads forward in some people to sensory cortex, even forward to motor cortex or speech isn't really known. About 100 years ago, the theory and why people called these vascular headaches was thought because the pain came at the vasodilation phase, but the pain actually starts when cerebral blood flow is really diminished. So vasodilation is not the cause of pain. There was a very nice article published by Mike Moskowitz, one of the Harvard groups, in Archives about maybe in April, looking at a mouse model of cortical spreading depression. This was very interesting because he induced cortical spreading depression by injecting either air bubbles or small cholesterol crystals or plastic bubbles in the carotid artery, and measured electrocorticograms, and also using laser spect he could look at the decrease in cerebral blood flow. And it's interesting, after you inject the bubbles, that within very shortly, within seconds, you'd find a decrease in cerebral blood flow, and then 1 to 2 minutes later you'd see the electrocorticogram spreading out. And what's also very interesting is that in patients that we do echoes with bubble studies to look for PFOs, we have, after injecting the bubbles, within a couple minutes, induced migraine aura and their usual headache. We don't mean to. Other types of primary headaches, again, you're not going to see the tension headaches. I won't talk about that terribly. You will see cluster headaches. These headaches, as opposed to 4-hour to 3-day headaches, are 15-minute to 3-hour headaches. They're usually quadrant headaches, sometimes involving the whole side. They're also known as the suicide headache because they're extremely painful and they build extremely fast. People can have several of these a day, and a patient I saw 2 days ago would tell me that before he gets on his medication, his preventatives, his first one occurs at 4:30 a.m., his second one between 11 and 1 p.m., his third one at 8 p.m. So like clockwork. And of course, if you do PET scans on these poor folks that volunteer to be in the scanner during a cluster, you will see increased cerebral blood flow in the hypothalamus and in the ipsilateral carotid, as opposed to migraine, where the business is in the pons, close to the periaqueductal gray. Cluster happens in about 0.4% of the population, so it's certainly going to be a lot less than the 12% roughly that you see in the U.S. And this has a gender prevalence, men over women, which is also reversed. 80% of people, luckily, are episodic, but you will find people that have cluster every single day for over a year. As far as treating it, there was a nice study just published, which we've known that oxygen helps for 60 years. This was published, so we don't have to answer the question about blood gases for the insurance companies when we order oxygen. Peter Goadsby's group at UCSF did it, but 100% O2 for 10 to 12 minutes, tight-fitting mask at 8 liters per minute works wonders. Imitrex injectable is also approved by the FDA for treatment of cluster headaches. So good acute therapy while you are starting preventatives. In my experience, it takes 2 preventatives to help cluster. An AED and a calcium channel blocker almost always work. Topiramate and valproic acid are probably the best. And this is a time when you don't want to start Topamax at 25 milligrams a day and increase in a week. You want to get people rapidly up. Yes, they'll have side effects, but most of them would rather have that than the cluster. I don't know if there's a place for steroids in cluster. We used to use them a lot. The side effects of steroids are not pretty, but sometimes they're a good bridge while people are getting on the preventative therapy. Sometimes we'll also do short-term prevention. So people will tell you, my cluster will happen 1 hour after I sleep. And for those, sometimes it makes sense to take a sumatriptan or another triptan or an ergot like Cafragot at bedtime, although Cafragot has caffeine in it. Another wonderful delineation of a very disabling type of headache. I met a very interesting couple from Eastern Washington a couple years ago, and the first thing the wife said is, "My husband has the devil eye," and I didn't really know what that was going to be about. But he's very interesting, and this is the only time I've seen this type of headache. He's 27 years old, and he had sudden onset of headache. And these were, again, a lot like you'd think cluster would be. They were left-sided, retroorbital, extended to the ear, with a constant severe pressure, but frequently he would have stabbing, knife-like orbital, retroorbital pain. It would last a few seconds up to a minute, and it would happen up to 30 times a day, and it was excruciating. He didn't have any accompanying features as you would for migraine. And during the stabbing pain, his eye, and it happened in my office, so he'd go from a white sclera to beet red. It just would turn so fast. And it would stay during the stabbing, and then when that regressed, the color would go too. He would also become teary, and he'd have ear pain and vertigo. And vertigo hasn't been described before in this type of headache. He had been to a very good neurologist on the east side who had tried him on virtually everything that we use for migraine prevention, and indomethacin, which is also used in cluster-like short-acting trigeminal cephalalgias that I'm going to show you a slide of in a little bit. The Topamax was the best for him because it decreased the eye redness and tearing, and it reduced the stabbing intensity somewhat. But he had a job where he had to count things, and unfortunately it was really interfering with work. These are known by the short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing title, which we know more likely as SUNCT, and it's certainly a lot easier to say. These pulsating, stabbing, short-lasting pain stabs last anywhere from 5 to 240 seconds, but there are people that can have up to 200 a day. Unfortunately, there is no treatment for this type of headache, and I think people are now starting to look at hypothalamic stimulation. There are a group of headaches known as the trigeminal autonomic cephalalgias. These are chronic paroxysmal hemicrania, the SUNCT, an example of which I just showed you, and cluster headaches. These are separated from migraine radiologically as well as by clinical history. So again, if you were going to put a patient with migraine in a PET scanner, you see increased regional cerebral blood flow in the pons area. If you look at people with chronic paroxysmal hemicrania and SUNCT, you see increased blood flow there, but also in the thalamus. So there's something different about where those headaches begin, if you will, or at least are modulated, although we know very little about them. Chronic paroxysmal hemicrania, again, most of these are differentiated by the number of attacks, the attack duration, and what they're responsive to. The one that's not a TAC is hypnic headaches. And the reason I put that up there is this is the type of headache you might miss. It's the type of headache that starts in people that are about 60 or older. And hypnic headaches typically happen at night. So they'll wake people up between about 3 and 4 a.m. They tend to be occipital, but not always. And if you didn't treat them, they would go away within 3 hours. Neil Raskin, who was the first person to really describe many of our headaches clinically quite nicely and still is working down at UCSF, found that treating people with 300 milligrams of lithium and a cup of coffee at bedtime was a very, very useful preventative. Sex headaches. Those are headaches that will always get a patient into your office, and I think they're very frightening. They're also extremely painful.
Question: a hypnic headache,
Mhm.
bad headache, like subarachnoid hemorrhage. I'm worried I have
No,
bad headache.
it's actually probably a moderate headache. So you'll have people come in and they're bothered by getting up at night, and they'll say, "I have this terrible pain," but it's not a severe headache. Yeah, but it's every night. Yes,
So SUNT and cluster are a lot alike.
a lot alike.
If you look at those columns, do you think they're truly separate kinds of headaches, or is
Well,
one a subtype of the other? I just don't know.
Well, I think SUNT always has the redness. So it always is part of the definition. But the other thing is that cluster is actually treatable, and it's fairly easily treatable, whereas nothing has ever worked for SUNT.
And does SUNT have nothing to do with histamine? Did it used to be called histamine headaches, or?
I think histamine headaches are not SUNT, but you're right. The trigeminal autonomic cephalalgias have been known as histamine headaches. Yeah, I think they weren't really broken up into good categories at the time we were using that phrase. Yeah. The most common headache is 4.42, the orgasmic headache, and this is a type of headache that and it occurs equally in men and women. It's a headache that usually has an onset, usually in people's 20s, not earlier. But it can happen with orgasm, with masturbation, with activity that when you're almost there or there, someone takes a baseball bat and hits you on the back of the head very, very hard. It is a sudden onset, extremely excruciating headache. And obviously people don't want to repeat that, so then you're in your office. Now,
it's a painful form of birth control.
yeah, and it really punishes people that, maybe doing, anyway, never mind. But, though it's self-limiting, the one thing that you need to do is MR angio on these people. Even though the risk of sentinel bleed presenting like this is small, it's certainly not zero. And again, Neil Raskin was doing angiograms on everybody who presented with this prior to MRAs. So it may be 0.1%, but it's still there. If it's negative, fine, you treat people with verapamil and maybe pre-treat if they're going to have intercourse with indomethacin, and that really works pretty well, maybe about 30 to 45 minutes beforehand. And again, it's self-limiting, but you have to do that MRA. Migraine is a syndrome, and I wish I had time to talk about everything, but I don't, and I want to just this time, instead of going to pathophysiology, you'll hear more about that maybe next year, but I want to talk about the genetics, which I think is really fascinating. Migraine is a syndrome that actually can have the same phenotypes with different genotypes, which I think is very unusual and interesting, because if you look at familial hemiplegic migraine, where the aura is of hemiplegia, obviously, you could have the exact same headache, and we're looking at 3 different genes. FHM1 shows an abnormality in the PQ voltage-gated calcium channel. It's chromosome 19. You also have a second set of families that have FHM type 2. This is an abnormality in the sodium-potassium ATPase gene on chromosome 1. And then, again, the similar phenotype with FHM3, where you're finding accelerated recovery from fast inactivation of a sodium channel on chromosome 2. So I want to talk about another patient. In fact, this is one that Dr. Ransom called me about and Alana took care of. Very fascinating child. He was 15 years old at the time. He went to a party, and he's a typical 15-year-old. I don't know how people keep their pants up when they're only like the top of the thigh, but he's a typical kid. He went to a party with his brother. He got in a fight, and he was hit in the face, not very hard. But within a few minutes, he was noted to be confused and behaving oddly. And actually, it was a good thing that he was with his brother, because his brother had seen this before. He was taken to a community hospital ER and diagnosed with a concussion. and sent home. His tox screen was negative. There wasn't a significant amount of alcohol in the other hospital, and his head CT was negative. His mother knew that there was a lot wrong even then because he wasn't speaking, and he continued not to be speaking. They took him home, and then 8 hours after the trauma, he started dragging his right leg. He was still unable to speak, and then he would sit on a chair thinking it was a toilet. So again, a lot of confusion. He was brought to the University of Washington, where he was seen by the neurology service, luckily. By 36 hours after the trauma, he was there. He was found to have expressive and receptive aphasia, a right hemiparesis, right-sided neglect, I think right hyperreflexia, and a Babinski. Correct me if I'm wrong. I saw him, I think, a couple of days after he was admitted. The thing that recovered first, I think, was his weakness. He started getting better. He didn't need to be assisted from the bathroom to the bed by his parents. But the aphasia persisted, and he had some nonsense words by the time he was discharged from the hospital. And he came in follow-up to my clinic, and at first he really didn't talk. He couldn't follow commands. So if you asked him to touch his nose with his thumb, he might raise his hand, but it was so he knew that there was something he had to do, but he was pretty confused about what. In the hospital, we didn't really know what to treat him with. We tried acetazolamide and I think valproic acid as an outpatient, but it didn't bring his speech back, and we didn't really think it would, but it was, again, sometimes something to do. 3 weeks following the trauma, his strength was normal and his language came back. So by that time, he was following all commands. 3 weeks of aphasia in a kid that just had a mild tap to the face. Very unusual. We were lucky to get an fMRI while he was an inpatient in the hospital. His strength was improving, but he was still aphasic. And we're also lucky to get an fMRI when his language returned after he was discharged. I'm not going to really discuss these because I can't, but with the help of Natalia Kleinhans, who works in the research radiology, we were able to get these fMRIs, and these are not easy to get. First of all, when someone has receptive and expressive aphasia, you don't really know what you're testing. She couldn't get him to follow commands, so it wasn't worth, you couldn't test motor, and you couldn't really test expressive aphasia either because he couldn't repeat or talk. So what she's really testing is, what does the brain do when you tell this kid certain words? And we still don't really know, but if you're looking at increased blood flow or the activity of the brain, if you will, time 1 is when he had aphasia and time 2 when he was resolved. And I think it's interesting to point out that, if you look at the left hemisphere here, you're not seeing a whole lot of activity, whereas when things resolve, you're seeing activity in language areas again. So what can make the brain really not have activity for so long? Yeah?
Did they test, or did you guys test in addition to words like pictures, other kinds of forms of language, or I guess more modes of communication, besides just saying play ball? Or
You mean with the scanner? I think it would be very difficult when he's in the MRI scanner to really show pictures, and I'm not sure all the things that Natalia did. She spent a lot of time with him, and hopefully we'll have a little method section on what she exactly did soon. So what was interesting to us afterwards was to figure out really what was the underpinning of hemiplegic migraine for him. It was not familial. No parent, no siblings, no relative had even migraine, much less aura. I sent off the genetic panel for the CACNA1A, and it was normal. But and then secondly, we sent off studies to look at the ATP1 gene, and this showed actually a single substitution for arginine for glutamine that the geneticists thought might be pathogenic. And again, there's no way to validate this, but what was interesting is that when you look at the two reported familial hemiplegic migraine type 2 mutations, that at least it was in the same extracellular loop. Now there is precedence for mild trauma for mild head trauma causing neurologic abnormalities, and for example, in the voltage-gated calcium channel mutation that's known as S218L, you can see seizure activity and cerebral edema after trivial head trauma as well. So all these clinical activities have been noted after trivial head trauma, not just the hemiplegic migraine, but also episodic ataxia and seizures and cerebral edema. It is thought to enhance cortical spreading depression, but again, theoretical. When you look at ATP1A2 mutations, there's again the familial hemiplegic migraine, but also childhood absence epilepsy and generalized tonic-clonic seizures. I'm going to finish by talking about treatment. Usually we stop at acute treatment. You diagnose a headache, you've got acute therapy. We also go one step further perhaps and try to figure out if there's anything our patients have that is a trigger that we can manipulate. There are some things you can manipulate and some things you can't. You can lead a horse to water, you can't make them drink. You can tell them that 7 or 8 hours of sleep would be better than 5. You can manipulate hormones by putting people on continuous oral contraceptives so you don't get the estrogen drop for menstrual migraine. You can try to get people to eat 5 small meals a day. But again, a headache diary and a good history may lead you to triggers, but not always does someone have external or internal triggers that they will manipulate or you can even recognize. And then for people that have many headaches, preventative therapy is warranted. I typically tell people I can't cure. I mean, it's nice to set realistic goals. And you have as many people as have headaches come in with different expectations. Care always has to be individualized. There's a difference between nonspecific treatment and specific treatment, and I'm going to talk about that when I show you a drawing. But typically nonspecific therapies, whether they're simple analgesics, Tylenol, aspirin, non-steroidal anti-inflammatory medications, combination analgesics with like Excedrin, aspirin, Tylenol, caffeine, opioids, steroids, they don't work at the migraine level itself, and I'll show you that in a second, whereas the ergotamines, dihydroergotamine, triptans do. And if you're going to write a toolkit for patients, for moderate headaches, you're going to do this. For severe headaches, you're going to do that. Don't forget people that have nausea and vomiting. The single biggest reason to go to an emergency room is because people can't keep things down. So it's rehydration and it's compazine. And you can give people compazine suppositories to have in the fridge that'll last years. If we think the migraine begins somewhere close to the trigeminal nucleus caudalis, then as it starts, the perfect storm, then you get stimulation of the trigeminal nerves. And again, remember these nerves conduct antidromically as well as retrograde and antegrade propagation. What we think the migraine is the release when stimulated of neuropeptides. Probably the most important neuropeptide is going to be calcitonin gene-related peptide. It's one of the most potent vasodilators in the body, and we now have CGRP inhibitors that are in clinical trials for migraine. Unfortunately, things are a little slow because they've had some cases of elevated liver enzymes. But if these get released, they diffuse over to the medium-sized arterioles and cause vasodilation, release of histamine, bradykinin, serotonin, albumin, and where these drugs work if they're acute. So let's talk about 5-HT1B1D receptors, the triptans and dihydroergotamine and ergotamine, as they act in 2 places. First of all, they act in the 5-HT 1D site, and they block the release of the neuropeptides. And they also have receptors that are called 5-HT1B receptors that are in the endovascular area of the blood vessels, and they will cause vasoconstriction. So they're very specific. Probably the non-specific medications work somewhere in the pain pathway. We don't really know where the non-steroidal anti-inflammatories work. Perhaps it's in prostaglandin, treating the prostaglandin release in the vasodilatory phase of the blood vessels. These are graphs of, this is a list rather, of migraine-specific treatment choices. We have all the triptans, sumatriptan, which went generic and hasn't worked as well as the brand in about 50% of patients. Sumatriptan joined by naproxen, known as Trexamet, which works quite well in terms of longevity as well. Zomig in different formulations, Emerge, Maxalt or rizatriptan, Axert, Frova, Relpax, and then dihydroergotamine, which is a wonderful drug, about 30 or 40 years old, but unfortunately in an injectable and a nasal spray, although it is soon to come out in a very interesting turbohaler. So you breathe it in and it just gets absorbed through the lung alveolar space very rapidly. Pharmacology, I'm not going to go into that except to say that if you look at the package insert, usually the Tmaxs are people that don't have headache. The interesting thing about having a headache is it delays the Tmax, and usually it's between a half hour and an hour. Whether that's because of gastroparesis or the migraine isn't entirely known. So the lesson there is treat early. Most of these are metabolized by different pathways with the exception of Relpax, which is a CYP3A4. The worst trouble you could get into is raising the blood level of Relpax if someone's on ketoconazole or the antiretrovirals. So at first visit, diagnose, give them therapy, remind them that headache can have recurrence. Recurrence means that after successful treatment, you might get the headache coming back 12 to 24 hours later. It's a property of all the triptans. They don't turn off the generator or modulator. They turn off the headache at the efferent stage, I think. Give them backup therapy. If the pill isn't going to work, they might have a prescription for an injectable. Maybe they won't use it that often, but it could avoid a trip to the ER. And if possible, that they do go to the ER and they're trustworthy with rescue therapy, dilaudid suppositories, fentanyl sucker, something like that might also prevent ER visits. And remember to treat nausea and vomiting. I want to just have a list of the preventatives that I use. There's nothing new here. None of these was directly looked at to treat migraines. They're all borrowed from something else. Antidepressants, cardiovascular medications, AEDs. The only ones approved by the FDA, which means they've been looked at in placebo-controlled double-blind trials, are 2 beta blockers for propranolol and timolol, which I never use. I typically use metoprolol, extended release, or Nadolol, and divalproex and topiramate. I hope you have access to these slides. I don't think that was made as a handout. Okay. Comorbidity is how I use to treat, is how I pick what preventative I'm going to use. If you look at odds ratios of migraineurs with depression and anxiety, you will see about an odds ratio of 2 with depression, up to 5 in anxiety in different large studies. And again, you don't inherit migraine, you inherit a brain that supports migraine and other things. So if you have someone that looks like they're on the ceiling, a little anxiety, maybe you want to do an SSRI, an SNRI, an AED. If they're depressed, I think a combination of amitriptyline 10 milligrams and fluoxetine 20 milligrams is wonderful. Again, mitral valve prolapse, beta blocker, Raynaud's, calcium channel blockers, comorbid. These are all comorbidities with migraine. Thank you. The rest of the slides you're going to see after this, for your reading pleasure, is going to be a case of medication overuse headache, which is the most common headache we see in our clinic. people taking 22 Excedrin a day or 300 Percocet a month, and then the last slides are also for reference. It was my admitting orders for DHE protocol. If you have someone with a refractory headache that you either want to detox or you can't break the headache, so just for reference. Thank you. Do we have time for a question? Yeah.
So I just had a quick question then. In terms of all these different subtypes of headaches, is the kind of going theory that all these different types have the same theoretical reason for why this is happening? Because I know specifically with migraine, the cortical sweating depression theory is kind of long been posed as the main thing, but then with all the new types, that third category, is there another kind of model that they're using, or is it all kind of variations off of that?
It's pretty much variations off of that. I mean, one model is the a serotonin soup. So, and usually rat or mice or cats are used, but you may peel back the dura and then just drop a mixture of serotonin, bradykinin, histamine, just something that's very irritating that actually that causes the spreading depression. Moskowitz was a different way. He was actually trying to get at the underlying theory why we're looking at PFO and trying to close PFO for migraineurs. And indirectly, I think he did us a real favor by showing us where the relationship between migraine, which is probably a hypoperfusion state, and cortical spreading depression was. I didn't get a chance to talk about some JAMA papers that were reported on a couple years ago with white matter lesions and migraine. About 30% of your folks with migraine are going to have these small dots, usually at the gray-white junction. And I think Dale Moskowitz is getting at why, because he took these rats and he had them in his little 9.4 Tesla rat scanner, and he only found one with a stroke, and that was when he really injected a pretty big quantity of plastic balls. I can't remember what they call them, and then he actually did the histopathology, and he found a lot more. A lot of damage with hypoperfusion, a lot more than you saw in the scanner, even a 9.4. So yeah. And I think now things are going to pick up. Why do some kids get? We heard Stan Herring a few months ago. Why do some kids get these headaches or confusion when they get hit in soccer? And it might not be or football, and they might not really be bad blows either. I think Stan showed the number one head injury is going to be boys playing football. Number two is girls playing soccer. And sometimes it's a fall and you hit your head, but you can get up and play again, and then suddenly a few hours later you'll have these chronic daily headaches. They're interesting. So it's probably going to be somebody like our patient. You've got some sort of genetic predisposition to have this happen. Yeah, it's fascinating. Yeah.
I have two quick questions. One is whether the drugs like Viagra are increasing the incidence of the orgasmic headache, and the other one whether there's any relationship between having herpes type 1, which resides in the trigeminal nerve, and any effect on migraine.
Viagra and company do not cause orgasmic headache. They'll cause headache all on their own, just because of the vasodilatory capacities, so to speak. And that's a common side effect. I have a young man with really bad pulmonary hypertension that has to be on Viagra 4 times a day. It saves his life, but he has hideous headaches and never had a history of them before. So it's a problem. And I don't know of any relationship between herpes and the incidence of migraine, although, of course, when you have it, you can have a headache with that, but I'm not aware of a relationship.
There were a few reports of sudden blindness with Viagra, and the local company, ICOS, that had some of the original involvement in developing this drug, consulted a lot of people, including me, about optic nerve injury. There was very little there. this phosphodiesterase inhibitor there is phosphodiesterases in optic nerve, in other areas of brain, but really there wasn't very much to suggest a problem. And now, millions of doses later, we don't have much to show for it in terms of human pathology.
But a lot of people are very happy.
Questions from Harvard U.
I'm sorry, what?
You should look for questions from Harvard U from their website.
Oh, I'm sorry. How do I do that?
Close
you
your exit.
Just exit.
Escape.
There you go. Now click.
Remote site questions.
There you go. Bingo.
Remote site questions. Thank you. Just want to double click. Sorry, Joanna. Would it be possible to send out the slides to the residents?
It'll be on the website. hopefully
Website?
within the next week or so.
Comes with parking. Okay. Yeah. Thank you. Thank you for that comment. Thank you. Thanks for your
I have
attention.
one
Oh.
more question.
Okay.
Vestibular migraines. What do you think of that entity? It's not in the IHS, right?
No, I'm in such arguments sometimes with our ENT folks. It seems like everybody in ear, nose, and throat sees vestibular migraines, and nobody in the headache clinic does. But I think we're arguing about aura, and some people can actually get vertigo as an aura. Problem is, when you don't have the headache, or you never had a history of migraine, to really put it in that camp, and that's a little bit problematic. It's sudden onset; it doesn't develop like a regular aura, And I think it's true. I just think you need to rule out everything else until you can do that. And I had a woman today who actually described hearing loss and tinnitus about 30 minutes before she had a headache. That's a little bit easier when you've got the headache following it. And actually it lateralized to the side of the headache. So there are some unusual syndromes out there, but the vestibular one, it's difficult.
Sylvia, that was a great lecture, and
thanks.
you could lecture to us every month, and we'd learn new things each time. One thing that continues to perplex me, 12% of the population has migraine headache, and a substantial percentage of them, it's strongly familial, powerfully familial. I appreciate that this could easily be polygenic, there could be multiple genes, but is there any new stuff on this? Any new gene that might have popped up as a good candidate to account for a lot of this strong genetic inheritance?
I think it's really, it's a great question, and I think that there's some tantalizing reports, like finding genes with families who don't have aura. But I think those are, they're very difficult studies to do, obviously. Getting the marker gene, so you have to, bring in how many, 100 people, some of which have migraines, some of which don't.
Tom, our resident gene sleuth, has trouble when there aren't sizable pedigrees, but that's not a problem here. We've got giant pedigrees. We could bring in thousands of people.
Yeah, if we had.
And that's being done. The name of the game right now in genetics is called the GWAS studies, these genome-wide association studies. And they're being done of every disease, particularly the common diseases. And migraine is in there, and I don't have a specific answer to your question, but I can find it readily. And there have been a couple of these these genome-wide association studies of migraine, and they have thousands of cases. And the problem with all of these studies is that they are finding genetic hits, and they don't know exactly what to make of them. They don't know how they're connected functionally, physiologically with the disease, and they don't know what their contribution is. Is it contributing 1% of the genetic influence, or is it contributing 20%? And it's very hard to sort those things out. So there's actually a lot of data coming out, but they're difficult to interpret.
There's a lot of private companies that are kind of interested in this, but also for for the last couple of years, anytime we do a clinical trial, they'll ask for a vial of blood to look at the genomics, and that actually hasn't been as easy to get through the human subject as I thought, because there's a vial of blood there, ostensibly do genomics, but what all? I mean, it's a little bit tricky.
Can I do one thing, and people don't have to participate in this little exercise if they choose not to. It's a violation of HIPAA, I suppose, formally speaking, but I'm just curious, in this room, how many people would volunteer that they have migraine headaches?
Wow.
Okay,
Wow.
that's pretty good. And I don't know if we're all here because
You're here.
who's schizophrenic in the psychiatry audience. You get a pretty good show of hands. But anyway, okay, great.
Isn't
Thank
it
you.
your requirement to do a neurology residency?
It's always over. I asked that in neurology. Whether doesn't matter what the talk is. It's always overrepresented for neurologists. There must be something genetic about going into neurology and having.
Sylvia, I also think that a lot of people with migraine, I have migraine, have mild migraine. So they're really not so troubled, but very clearly they have paroxysmal headaches, and they may have a family history, and they know they have migraine. But it's not so bad, it's not incapacitating. I always find my patients are reluctant to accept a diagnosis of migraine if they're not bedridden by this, because
Right.
they've come to understand that this is a flat-out incapacitating headache. Clearly I don't have that.
Yeah, 50%. If one parent has migraine, it's about 50% of the kids. If two have it, it's about 75%.
Wow.
That I found in getting the histories. That's,
Thanks again.
yeah.
Sylvia.
Thank you, everybody.